just a bit of a refresher on Varenicline or Champix and how you can use it with your clients. First off, I thought I'd just quickly cover a little bit of the history, because this medicine's been, well, hasn't been around for that long, since 2006, but the molecule itself has been around for much, much longer. And the history, as many of you know, is that Varenicline was developed from cytosine. You know, cytosine is found in a number of plants. It, to the brain, looks a little bit like nicotine, and so can alleviate craving and some other withdrawal symptoms. But in its form, initially, it was in seeds and leaves. And even during the Second World War, German soldiers would used to take the leaves of the Cessation laburnum tree, roll it up and smoke it. So it was sort of a bit of a tobacco substitute, where tobacco was not readily available.
Hayden, it's interesting that cessation is also present in the kowhai tree here in New Zealand. Is that right?
It is, that's correct, Grant. So it's found especially in kowhai seeds. So we have our own ready source of cytosine. Some of you, I don't know about you all, but I was told by my grandmother when I was a child never to chew on those seeds because they'd make you sick. And just like nicotine, it has the same sort of effects, especially in young children, with nausea. And that's one of the side effects of cytosine and one of the side effects of Varenicline. Anyway, Pfizer decided that they'd look into this a little bit more, and they started exploring how they could change the cytosine molecule a little bit. And that's what they did. In 2006, they finally got everything going, ran a couple of big trials, and showed that Varenicline could actually help people stop smoking. It hasn't all been smooth sailing for Varenicline, as many of you have been around since its launch in 2006. A couple of years later, there's starting to be reports of severe neuropsychiatric adverse events. That is, suicidal ideation, or people becoming really depressed, or their mood just becoming weird. And people started to get worried. And I remember even here in New Zealand, some people thought that it should be removed from the market. The FDA, the Federal Drug Administration in the US, put a black box warning label on it. So that was just to warn prescribers of these events. But over time, things have settled down a little bit, and I'll cover some of these data to show that actually Varenicline doesn't cause suicidal ideation. And a few years ago, the FDA actually removed its black box warning. So we're all back to normal again after a little bit of a rocky road. Now, how it works, I think the key thing to remember for explaining to clients is to keep it simple. And Varenicline works in a couple of ways. It reduces craving for cigarettes and makes quitting a little bit easier. But it also, whilst people are taking it and they're still smoking, and they need to do that for at least a week before quitting, is that it can reduce the enjoyment of smoking. And what you're looking at here in this picture is exactly that. So here's the molecules of Varenicline shown here. It's binding to these nicotinic acetylcholine receptors. It's giving rise to dopamine release, as you know, in the nucleus accumbens, which is going to lessen the craving. But it's also sitting on these receptors and blocking nicotine here from binding. And so that's why it has this effect in reducing the enjoyment of smoking. Now, not everyone gets that reduction in enjoyment particularly quickly, and it might take a few weeks for people to experience that.
Hayden, if Varenicline blocks the nicotinic receptors, why is it not a magic cure? Why doesn't it just...
Yeah, so it has both effects actually, Grant. It both stimulates and it blocks. Okay, so this is why it's called a partial agonist. So it essentially binds the receptors. It gives rise to dopamine release. Okay, but not as much as smoking. Here's smoking over here in this picture, and you can see lots of dopamine being released. Here's the effect with Varenicline. You still get some dopamine release, more than going cold turkey, but it's much less than smoking. So that's why it's no magic cure. It's not exactly like smoking.
Okay. And just to clarify, what exactly is the nucleus accumbens?
So the nucleus accumbens is sort of the reward center of the brain, if you like. So it's a part of the brain which you innovate or you stimulate these neurons, these nerve cells, and their action is to give rise to this dopamine release in the nucleus accumbens. And to the brain, it says, yeah, that behavior was good, let's keep on doing it. So it's essentially a reward center.
Right, okay.
Okay, very quickly, does Varenicline work to help people stop smoking? Yes, it does. These data are from the Cochrane Review. They pulled together 27 studies, and you can see there that it over doubles the chances of long-term quitting. Okay, this is an effective aid. It's probably one of the most effective aids for smoking cessation, up there with combination nicotine replacement therapy. Now, oops, the big, I know forest plots, you're getting used to me showing forest plots now, but I just want to pull out a couple of things, and I've summarized what these funny things are showing. This is looking at the studies that compared Champix, Varenicline with bupropion or Zyban. And what all of these studies show here, put together, is that Varenicline is more effective than bupropion. Champix is more effective than Zyban. Okay. And this forest plot down here, you can see a few mixed studies, but overall, it's also showing that Varenicline is more effective than single product nicotine replacement therapy. Okay, but it's not more effective than combination NRT. They're roughly the same. Oh, one thing that I just wanted to mention, because we sometimes forget about it, Champix here in New Zealand, or Varenicline Pfizer as it's now known, is subsidised only for a 12-week course of treatment. But it can be used for longer. So people can use Varenicline for 24 weeks if they want to. They just have to buy the second 12 weeks themselves, and I'll show you the cost in a minute. But there is some evidence to show that extending the course of treatment can be helpful. And this was a study where they gave everyone 12 weeks of Varenicline to start with, and then they randomly allocated people to get another 12 weeks of Varenicline or 12 weeks of placebo. And you can see here we're starting with everyone that had had the 12 weeks and was still not smoking. And this is the line in those that were allocated another 12 weeks of Varenicline versus placebo. And you can see this difference here at week 24. So for many people, the extended course of treatment helped them stay stopped for longer. Now, they followed up people in this study all the way to a year. And although the gap closed a little bit here, there was still a significant difference in long-term quit rates. Now, I'm not advocating that everyone should go and get their initial 12 weeks and then go and pay for another 12 weeks. But those that might benefit from extended use are those that kind of just sort of, I call it staggered into abstinence. They sort of didn't start very well, they struggled, they keep slipping, but they got there in the end. And maybe they got there in the last 4 weeks of their treatment. So those are the people that might benefit from ongoing use. Other people might be those that are still really struggling with withdrawal symptoms or craving. And they really just need that extra ongoing support to help them stay stopped. So it is licensed for 24 weeks of use, but just remember the last 12 weeks they need to buy it themselves, and that can be a barrier for some people. Now, as you know now, the old branded version here, Champix, is gone. This is the new generic version. It's called Varenicline Pfizer, and you can see there in the bottom the difference in the list price. So it's good old generic branding here now. We've gone down to under a quarter of the price. Now, this is the list price. So this is the sort of cost to the government, so to speak. I've been told by pharmacists that if people had a non-subsidized prescription, that this would be roughly double the cost in the pharmacy if they went in with that. Okay, so if they got a prescription that wasn't by a special authority, then they'd probably have to pay around $50 for the first 4 weeks and around $60 for the continuation pack. But still, that's not too bad.
Is that due to pharmacy markup on the product?
I think so, Grant. It's that and some other things that I don't really know. I don't really know about why, but certainly shopping around before you hand over the prescription might be a good idea.
Okay, you're probably going to get into this later, so excuse me if I'm circumventing your process here, but should all stop smoking practitioners be discussing Varenicline with their clients on their first meeting when they're talking about NRT?
Absolutely, they should. And you know what? We should be giving people the best options first. I know it's easy to talk about NRT because it's simple, but you know what? Most people can take Varenicline. The only people that can't are those under the age of 18 and pregnant and breastfeeding women. And those with severe renal impairment, i.e. they're on dialysis or something like that. So actually NRT and Varenicline are really open to everyone. Some might say, oh yeah, but they have to go to a GP. Well, I think we could be working better with our GPs to try and make this more accessible for people who smoke.
Yeah, because I get the feeling that quite a few stop smoking practitioners are a little bit worried about talking about a prescription medicine, and they find it hard to overcome that worry with their clients. How would you recommend that they
Look, one of the easiest ways to discuss this is just to follow the scripts in the NTS handbooks, or now in the new individual treatment manual. Don't feel afraid just to explain that. Some of what people will say is, oh yeah, but I heard that causes depression, or I heard that causes mood disturbances. And you can say, well, actually, we know that it doesn't do that. Stopping smoking can cause those things, but this is not a drug effect.
Okay. And what about people who are on a lot of other medicines?
Oh, really good question, Grant. There are no other drug interactions, so this can be used with any other medicine whatsoever. It's very much like NRT in this way, nice and simple to use.
Okay, great, thank you.
So here are don't need to go into this too much now because we've discussed it. So the only people that can't use it are end-stage renal disease, and people will know if they've got that under the age of 18. Pregnancy and lactation, they put in these precautions, but in most cases it would be, well, let's use nicotine replacement therapy. Those that are renally impaired, you can reduce the dose. You don't have to worry about that because the doctors will do that for you. Okay, and as Grant just mentioned, there are no drug interactions to worry about. Okay, so when people say, can I take paracetamol on this, you can say, yeah, no problem at all. And when they show you their big list of medicines, you say, don't worry, this doesn't interfere with any of those. Dose is really simple because you just follow the instructions on the box. But as you all know, this starts with a low dose and increases over time. And this is really just to limit some of the side effects. So people start with just 1 0.5 milligram tablet for the first 3 days. You can just take that in the morning. And then they go to 1 tablet twice a day from there on. And the dose rises from 0.5 milligram twice a day to 1 milligram twice a day. If people are quitting abruptly, so you've got people there saying, yep, I'm ready to go, remember that it does take a week to sort of kick in. So the quit date should be somewhere between day 8 and day 14. If you've got people that are going to use a flexible quit date, and I use this quite a lot with Champix, I say, look, just let the quit date choose you. Take this for up to 4 weeks and just see, where you want to fit in with this. You'll know when you get to that date. So I usually give them 4 weeks for that flexibility to set their quit date, and then they've got another 8 weeks afterwards. As I've already mentioned, you can continue for another 12 weeks, but that's not subsidised.
And are there any risks to people who are using Champix who have sliced cigarettes or
No. None at all. And that's one thing you should say, just no matter what happens, keep taking the Champix.
Okay.
Yeah. Now, some people get worried when they stop any sort of medicines. There's no risk around stopping this abruptly. But if people are a bit concerned, you can say, hey, look, why don't you take your last few weeks of tablets and just go down to one tablet once a day, so you can do it that way. Don't tell people, oh my goodness, yes, you might have withdrawal symptoms and you might have this. Reassure them that most people have no problems in coming off their medicines. If people are really worried, you could arrange extra visits or maybe some phone calls just to help tide them through that time as they're coming off. Side effects, two most common side effects: nausea. If people feel sick, you can advise them to take the tablets with food. Mostly it's mild and quite well tolerated. The thing that sometimes upsets people are strange or vivid dreams. And so I always warn people about these. They're not necessarily nightmares. Some of them are pleasant dreams, but just know about those. Other things people might report, well, they may not report it, but it's not uncommon as flatulence and a little bit of insomnia.
Just with the dreams, Hayden, if people are having dreams that are disturbing and it's keeping them awake all night and they're tired during the day and can't drive for work or whatever, what do you advise that they do?
So you could try taking the tablet a little bit earlier. So just check when they're taking it. Usually I advise people to take their morning tablet with their breakfast and their evening tablet, with their evening meal. But if, some people do eat just before they go to bed, so you could take this. You might have to recommend times. So you might say 8 o'clock in the morning and 4 o'clock in the afternoon.
Okay, and that will help with the vivid dreams.
It can help, but maybe not completely. It can certainly help with the insomnia, which is typically what people struggle with. Having vivid dreams doesn't make you tired.
Right.
Kia ora, Hayden. Sorry, I just have a quick question. I'll jump in there while we're on the topic. So I have had that same situation with some of my clients before around the dreams, around nausea. What I have advised before is that if the taking the pill before, way before bedtime doesn't work, then halving the pill, is that something that can be?
Look, you can, but these tablets are enteric coated, so that sometimes can change the absorption. Out of all the time I've used Champix, I've never had to reduce the dose for people.
Right, okay.
Most of what I do is reassure people it's okay, they'll get used to it over time, and most people do. One thing you can do, though, is this often appears in my experience in people, and they're mostly women, who are really slight, really thin, way under 50 kilograms.
Right.
Actually, one tablet a day might be okay for them.
Okay. Oh, very good.
So just do the morning tablet.
Yeah. Oh, and with that also it stretches out the amount that they have.
Yeah, it does, absolutely.
Yeah, rather than 12 weeks, you get an extra couple of weeks with it.
Exactly. Yeah.
Awesome. Thank you.
Yeah, good questions. Suicide, is this something we need to worry about? As I mentioned, there were all these concerns that started back in 2007. The short answer to this is no, we don't have to worry. We don't have to worry about the fact it's a drug effect. But just keep in mind that many people who smoke have a history of depression and mental illness. So you're more concerned about them as a person as opposed to a drug effect. And why I say we've got evidence to suggest that this is not a drug effect is this very large study. This was an industry study, so Pfizer sponsored it, but GSK also contributed because there's Zyban in here as well. But they took over 8,000 smokers, half with a history of psychiatric disorders, so half with a history of mental illness, and you can see that most people had depression, primary affective disorders, so mood disorders. There are a few people with psychotic disorders in there as well. And then the other half of the population had no history of psychiatric disorders at all. And they randomized these people to one of four arms. varenicline, bupropion, nicotine patch, or placebo. And this is what was called a triple dummy design. So if you got real varenicline, you had to take dummy bupropion and dummy patch as well. Okay, so that's how they sort of fooled everyone into thinking they were at least on something. If you were a poor person in a placebo arm, you had to take dummy varenicline, dummy Zyban, and dummy patch. So you had nothing working there. Now, the main outcome of the study was looking at a composite scoring, if you like, of these neuropsychiatric adverse events. So these are sort of the side effects that are related to mood or depression, suicidal ideation, etc. And look, I'm not going to go into detail here, but if you just look at, this is the people without mental illness, and you can see here the incidence of these adverse events, these neuropsychiatric adverse events, was fairly low. The important thing to note here is that there was really no difference between those in the placebo arm versus those in the active treatment. Although, actually, those that had varenicline were the least likely to experience any neuropsychiatric adverse events in the non-psychiatric, those without mental illness. Those with mental illness, I think you'll see here that they were just more likely to experience these symptoms. So, around the 6% mark. But again, there was no significant difference in the active treatments versus placebo. Okay, so I think this gives us some reassurance that these medicines, including NRT, do not cause suicidal ideation or depression.
So, so what you're saying there is that it doesn't matter what psychiatric illness a person may have, they can safely use Champix without making it worse.
Yeah, right. Absolutely. But if you've got someone with mental illness, you're going to provide them with a bit more support anyway, because that's what you do. So you're absolutely right, Grant. You can use varenicline in all of these groups, and you know what? It works in all of these groups. And this is just showing you the 6-month quit rates. Blue bars are varenicline, green bars bupropion, purple patch, and red placebo. And this shows the same pattern that I talked about earlier. Varenicline is more effective than bupropion and patch. It doesn't matter whether you've got no mental illness or you do have a history of mental illness, it works.
And it works safely.
Yeah, it works safely. And there have been a whole lot of different studies now. Here's just an example. I won't go into it in detail here, but this was looking at people with stable major depressive disorder, and they were randomized to get Champix or placebo. And you can see these big differences in their quit rates here. So really, really good to see. It's also been used in people with physical illnesses. This is an example of use of this medicine in people with chronic obstructive pulmonary disease, so emphysema, chronic bronchitis. What it shows here to me is if you're seeing people with COPD, and the same for cardiovascular disease or peripheral vascular disease, if you treat them with almost nothing, this is placebo here, you get really low quit rates. This is really not what you want to be doing in anyone with chronic or long-term conditions who smoke. They need the support. And just to show you that again, with these are people with stable cardiovascular disease, again, safe to use. There's also been a study using it in people that are in hospital after acute cardiac event, and it too is okay to use in those people. Okay, so again, getting back to Grant's earlier point, it's all okay to use in this group. I mentioned this before, flexible quit date. There was a study on this. So this was letting people choose their quit date. They could choose it between end of week 1 and the end of week 5. I sort of say to people, choose your quit date in the next 4 weeks after starting taking the tablets. But it's a much nicer way. You've got someone that's a little bit unsure. You say, let the quit date choose you. Wait until you're thinking, this is going to be it. I'm not going to smoke again. And it can be a nice way of easing into it. For those that are willing to perhaps purchase extra Champix down the track, you can use a cut down then quit approach as well. So in this study, they used the first 12 weeks of Champix to reduce their cigarette consumption, and then once they'd quit, by week 12, they had another 12 weeks of support after that. And again, you're seeing these really big differences in quit rates here. So there's different ways of using this. Unfortunately, in New Zealand, with our current subsidy, it does mean that we're a little bit restricted with cut down then quit, but if people can afford to buy more themselves, then it's still an option to use.
So with the cut down to quit process, they would be smoking as normal. They would start on the Varenicline.
Yep.
Then the practitioner would say, go from 20 cigarettes a day in the first week down to 10 or 15. And then
a good way of doing this is I like to go, in the first 4 weeks or the first month, I want you to halve your cigarette consumption. Now, most people can do that really quite easily. And then they're feeling like, yeah, I can do this. So, okay, second 4 weeks, let's go down by another half. So they go from 20 to 10, then 10 to 5, and then they've got another 4 weeks to aim to stop smoking completely in that time period.
And the whole time they're using Champix.
And the whole time they're using Champix, yeah. Now, in my experience, people can tend to do this quite, that you'll set these big time frames, but they'll come back and they'll say, you know what, 2 weeks, I've already cut down by 75%. You check your targets then a little bit, so you can move things a little bit quicker. And I think once people get that, then they can really make a difference.
So Hayden, just a quick question: with the extra 12-week course of treatment, do they need a script for that, or can they just go?
Yes, they still need a script for it. It just won't have the special authority number on it. Okay, and that's also the same. Say you have someone that's had Champix 6 months ago, so they're not eligible to have it again for special authority. They could go back and just get a prescription from their doctor and pay for it. Okay.
Also, one other question while you're still here. Some GPs, especially down here, actually struggle to prescribe Champix rather than the Zyban.
Yep.
So is there any way that they can be, I guess, educated or get some information around it? Because we don't think it's our job to actually educate them.
Yeah, it'd be nice to think that, but I have this feeling if you don't do it, then nothing will happen. So if you can get in and just sort of talk with them and say, you might not even be aware that this has changed now and this is much cheaper for clients. And when we send clients to you, this is what we've told them. We've told them that there are no drug interactions. We've told them that these medicines don't cause suicidal ideation or anything like that. So you could probably educate them in a way where you're saying, this is what we do, but you can bet your bottom dollar that they won't know much about it. So don't feel afraid about doing that.
Thank you.
And this is just a quick reminder that there are many people that have tried Champix before and failed, but doing it again, you can still get really good quit rates. So here's 1 year quit rates, 20%. It's still pretty good, and actually it's a little bit different than NRT. Often with NRT, you see that the more they've tried, the lower the quit rates later on down the track. This seems to be a little bit different there. Nearly done. In fact, here we are. Last slide. Don't forget, this is a tool that's really important for us to use. I think we could probably do a little bit better in working with GPs. I mean, one of the things that you mentioned already was, it's difficult for GPs to prescribe, but then on the other hand, they also prescribe but don't get them into stop smoking services. And this is where we've got to be able to join up those approaches much, much better to get the best we can for every single person who smokes. It is still fully subsidised under special authority, which means you have to have tried NRT at least twice and be enrolled as part of a program and not used it in the last year. It does require a doctor's prescription, and that hasn't changed. But what has changed is the new generic brand of Varenicline is significantly cheaper. So it's more affordable for people that can't get it under special authority. Do remember to talk to people about the common side effects. They're mostly mild. They do disappear over time. And also don't forget to use it in a different way. We're all really good with abrupt quit attempts, but if you've got someone that says, I'm not quite sure about my quit date, let them be flexible. Follow them up, check on how they're going. And if you've got people that maybe can afford the extended treatment, then you could look at the reduction to quit approach as well.
Sorry, Hayden, just another question, sorry. So is the special authority still the same? So they would have had to have used some other product before they can get special authority? That hasn't changed at all?
That hasn't changed. But if you were prepared to, let's say you hadn't used NRT at all in the past, and you said, yeah, but I really want to use Champix, you could go to your doctor and get a prescription for Champix, and you just pay for it. It'd be about, I guess, around $140 roughly for the 12-week.
Which is a lot cheaper than it was before, so that's good.
Yeah, much cheaper than it was.
Yeah. One other question, sorry, Hayden, before you go. Is it okay to prescribe, or not, sorry, prescribe, but to offer NRT with Champix?
Under special authority, no. That's one of the things there. I usually take an approach that if people say to me, oh, I've got some gum at home and it really helped me, then I say that's fine. There's no strong evidence that adding NRT on top of Champix adds a whole lot of extra benefit. But then, sometimes maybe just the mere habit of thinking, oh, I've got an urge to chew a piece of gum might be helpful.
Yeah, oh, very good. That's awesome. Thank you.
No worries. Anything else from anyone?
I'll just unmute everyone, Hayden, and then if there are any questions coming through, everyone should be fine now to just jump in if they want to ask you a question.
Sure.
Okay.
Hayden, I've had the odd person where they have felt really, really sick with Varenicline, and so I have about. I've told them about getting anti-nausea. That has worked at some times. So, yeah.
Yeah, that's another option. To be honest, in my prescribing experience, I've actually never prescribed an anti-nausea medicine to go along with it. I've always managed to deal with it in different ways, such as reducing it down to one tablet once a day. But yeah, you're right. If people are really struggling, that is another option for them.
And the cost is actually, so it's really around the $27 mark, $28 mark when they want to, because I haven't.
Oh, sorry, you cut out a little bit there, but were you making a statement about the price?
Yes, just when they had a little, another month, so they can get it month by month. You don't have to buy the whole 3 months.
No, you don't have to. The doctor can prescribe it, and I assume the pharmacists just break up the packs in that way. Yeah.
Right. And
yeah. Remember now in the new form, it's 4 weeks starter pack and 8 weeks continuation.
Oh.
So it's just those 2 packs now.
Hayden, it's Sarah from Nelson Marlborough DHB. Sorry, my webcam isn't working. I've never actually heard the statement before that NRT with repeated use that the quit rates fall. I've always thought that the efficacy stayed the same.
So the looking at use of NRT in people that have used it before, you seem to get this lessening of effects. Now that's from some relatively old studies, but overall, Sarah, as you might know, NRT purchased over the counter is probably ineffective these days. So just giving out NRT with nothing is probably a waste of money. Now, that never used to be the case, and I suspect it's got more to do with how the population of smokers is changing.
Would it hold true, though, to people, you know, engaged with a stop smoking service and receiving all the support that goes with that? I mean, it's just,
I think
it's nuances in the conversation that we have, isn't it? It's, you know, it's where I'm placing an emphasis.
Yeah, that's right. I mean, I think you've got to just keep in mind that, you know, studies that have gone through with people that have, you know, there's different products that have come out over time, and you know, maybe people moving from, you know, patch to gum to something else, you just get a bit of a burnout with it all, or, you know, the lozenge tastes as bad as the gum, and so that's really what you're seeing, as opposed to it just doesn't work anymore, like there's some sort of resistance to it. That's definitely not the case. So yeah, I think that if you're supporting people and supporting them well and really helping them use the product, then they can work.
Yeah. I also think it's really interesting, that comment about, you know, whose responsibility it is to educate the doctors, and I think we all sort of struggle there a bit. I'm wondering if there's any opportunity for a toolkit. I think it might be easier for us if there was a standard template, a letter, a fax form, or something that had got some higher level branding or stuff on it, so that that we could all use.
They're called the guidelines. And this stuff is in there. I got that 2000.
Give it to NTS booklet.
And there's NTS booklets. So yeah, I know this is a challenge, and I'm talking to our resident medical officers today at lunchtime as well, because the prescribing in you know, our area could be improved a bit more as well. So it is about getting out there and doing what you feel comfortable doing, but also knowing that over time, you know, with these relationships, you will make a change to behaviour.
Any last questions from anybody? No, that looks like us, Hayden.
Okay, thanks very much.
Awesome. Thank you, Hayden. Thank you.